We'll go ahead and get started. Welcome again, everyone, to the Youth Justice Action webinar series. Today's topic is Opening New Doors, Supporting Youth Justice through CalAim and CYBHI. As we get started, please do feel free to greet your fellow participants by sharing in the chat where you're joining from this afternoon. Couple of announcements. We welcome you to share your thoughts and questions throughout today's presentation. You may post your comments and questions to the chat throughout. Today's session is not available for STC or MCLE credits. However, the webinar will be recorded and posted on the OYCR Training Resources page. I will now hand it over to Director Lucero to get us started with today's introduction.
Thank you, Tara. My name is Catherine Lucero. I am the Director of the Office of Youth and Community Restoration. The purpose of the OYCR Youth Justice Action webinar series is to provide all juvenile justice stakeholders with information on practices and trends that highlight the shifting landscape of the juvenile justice field to improve outcomes for children, youth, families, and communities. The webinar series is held typically on the first Monday of each month to share best practices and pioneering research that promote a behavioral health approach to youth justice. OYCR was born out of SB 823, and our vision is to have a healthy California that enables all youth to be responsible, thriving, and engaged members of their communities. Our mission is to promote trauma-responsive, culturally informed, gender-honoring, positive youth justice to all youth involved in the youth justice system, and to support our youth's successful transition into adulthood and welcome them back into their communities after a period of incarceration. It is my great pleasure to introduce our panel of leaders and speakers today. You can find each of their bios posted in the chat. Will Lightbourne is a consultant for OYCR. He's a senior consultant. Autumn Boylan is the Deputy Director of the Office of Strategic Partnerships within the Department of Healthcare Services of California. Dr. Sohail Sood is the CYBHI Director for the California Health and Human Services Agency. Dr. Sharmel Shah is the Assistant Deputy Director of the Office of Health Workforce Development, HCI. And Dr. Tully is the Vice President of Partnerships, CUTH. Alex Briscoe is the Principal California Children's Trust and consultant to OYCR. And Dr. Juan Arguello is our Chief Health Policy Officer here at the Office of Youth and Community Restoration. Very excited about the information that you are about to get. And please remember that at all times, we are available to answer questions or to have you reach out to us aside from these webinars in case you hear something that's really, really important to you and you didn't quite get it 100%, because this information is sometimes can be a lot, but it's exactly what we need to shift the landscape and to serve our communities. So please join me in our first, welcoming our first speaker, Will Lightbourne, who will provide some context for the opportunities that you will hear today. Thanks, Will.
Thank you, Director Lucero, and good afternoon, everyone. I'm going to sort of do a quick walk down memory lane about how I think we got here. And these are highly opinionated observations, but I hopefully they will bring together where the transformation in our low-income programs for healthcare and our behavioral health programs for children and youth are going, along with where we've been moving in the juvenile justice space. Systems transform themselves really when they encounter difficult truths. In the juvenile justice arena, the difficult truth, of course, was that longer terms and more restrictive conditions tended actually to produce worse outcomes. And so we've been looking at how do we reshape the way we approach working with youth who have behavior that's come in contact with them. In the healthcare system, the awareness starts when we realize the United States spends about twice as much per capita on medical services as the next most expensive country and has the worst basic health outcomes of any of the developing countries. And coming to grips with that dilemma has helped the system re-examine itself. Additionally, within that dilemma is that the health outcomes for people of color is even significantly worse than the national data. The basic underlying reason, of course, is that medical services contribute about 20% to health outcomes. The remainder are the results of healthy living environments, safe neighborhoods, stable, adequate housing, nutrition, economic security. And nationally, we have not invested nearly as much on that end as many other countries have. This recognition of the social determinants of health is the backstory to the changes that are underway in our state programs in California. The other backstory lies within that recognition of the health disparities by race, and the fact that beyond worse conditions in social determinants of health, there's also the fact that people do better when they receive care from people who are culturally like them. And that isn't the case in our health delivery system, by and large, in the US. California has had an additional impetus to make change. The crisis of homelessness in California is not just a product of high rents and uncontrolled rents. It's also a product of poorly managed transitions from institutions to community. And by institutions, we mean hospitals, we mean prisons, jails, detention programs. Is sort of the large entry point. And in addition to being a humanitarian crisis and a social crisis, it also became for the health system a cost crisis, because this is a group of people who will heavily use the most expensive part of the healthcare delivery system, the emergency programs. And so California, at the time that the Affordable Care Act was expanding eligibility for Medicaid to single adults, and the federal government was paying almost all of it, California began a series of experiments locally involved, which we refer to as the whole person care model, to work with primarily public hospitals and community behavioral health, and really try to create wraparound services that started to address social determinants. As the experience of those pilots became more and more promising, the decision was basically taken to make that initiative statewide. Autumn in a little while is going to describe to you some significant parts of CalAim, but really sort of the history there was the recognition that it's possible by addressing specific populations with high needs and making available to them non-clinical services that improve the context in which their health is developing, we can actually get to a place of having better health outcomes, particularly for vulnerable populations. One of the key elements, of course, in this transformation was defining the populations that were of the highest priority. And among them were people transitioning from prisons, jails, and juvenile detention facilities. And that becomes the point at which this healthcare transformation meets our juvenile justice transformation at a sort of, I would say, a very propitious moment for both systems. The second thing that occurred, sort of causing us to recognize hard realities, was driven in some part by the pandemic. It the dramatically worse health outcomes for communities of color was obvious. Additionally, it brought us face to face with the mental health crisis that children and youth were encountering. These weren't caused by the pandemic, but the pandemic shone a spotlight on them. And so as a result, for the state, there was a very conscious decision to say, if we're going to try to address racial inequities in health outcomes, we have to start to resource and recognize those community health providers, the healers, the people that the community naturally turns to, and start to make them a part of the health delivery system and resource them. And so that expansion of eligible provider categories is a key element in what's now unfolding. And then the other part, the recognition of the crisis of our children and youth in mental health, led to the very ambitious, very dramatic Children and Youth Behavioral Health Initiative, which we will be hearing from Dr. Sood and his colleagues to sort of describe how these services, which will essentially be delivered mostly in a sort of a school or a technological environment, become available. That to us, to me, is critical for us in the juvenile justice transformation area, because the vast majority of the youth that we're concerned with actually live in the community, not in detention facilities. And so their ability to have their behavioral health needs met, regardless of reimbursement source, is essential. And so that's sort of another piece that has sort of moved us into a place where I think we can sort of see opportunities and make progress in bringing services to the youth. Our challenge is that most of the providers that are familiar with our youth, work with our youth, provide services to our youth, are not embedded in the health delivery system. Many of them don't speak the language of healthcare financing. They aren't familiar with the managed care plans, who are serving as the vehicle for these reforms. And so our goal at OYCR, and we'll have a presentation on this, is to provide the technical assistance to those community providers who are the natural people that the youth look to for help, and to help them become providers in this new environment. There are a couple of things we're not going to talk about today. We can do in subsequent webinars. The Department of Healthcare Services is negotiating a new waiver with the federal government to expand behavioral health services, especially for populations of youth. And last March, the voters of California passed Proposition 1, which presents a significant new investment in sort of resources for behavioral health facilities, and redirects some existing resources to support the programs that will be built out of that. My colleague, Dr. Arguello, will comment on those as we close out today's webinar. But as I say, we can address those in detail in a future session. So with that, I would like to introduce with great pleasure and excitement a long-time colleague, Autumn Boylan from the Department of Healthcare Services.
Thank you so much, Will. I'm so happy to be here this afternoon presenting on today's webinar, and I plan to share a little bit about the work that we're doing for the California Advancing and Innovating Medi-Cal, or CalAim, Reentry Initiative. Excuse me. We have been working very closely with stakeholders and implementing partners over the last 3 years to really shape this reentry initiative program at the state level, but working closely with our county partners. This opportunity that we have to engage in a waiver of federal statute, which had previously prohibited the use of Medicaid funding in correctional facility settings, is really an exciting opportunity for states across the nation. And California was the first state in the nation to receive approval for its 1115 reentry demonstration waiver, but now many other states are following suit, and still watching what California is doing very closely. So as we get closer and closer to go live of this reentry demonstration, we're getting closer to realizing the goals that we've set out for California's justice involved populations, but also for realizing the goals that we've set out in terms of leading the nation in the work that we're doing to create a more coordinated reentry for individuals who are leaving correctional facility settings, entering back into the community and giving them those kind of wraparound supports that are needed to ensure that individuals' needs are met, and that there's an opportunity to build trust with a care team that will follow that individual into the community and provide the necessary critical support to support the individual's whole health, whole person needs. And we'll talk about that a bit more in just a moment. But really, through this reentry demonstration, we are hoping to increase coverage and continuity of care. We want to make sure that there are services available in the carceral settings prior to the individual's release. So the waiver actually authorizes pre-release services to be provided to individuals who meet specific criteria, although for youth, there are no criteria or healthcare criteria that youth need to meet, but really making sure that youth get access to the physical health, mental health, and substance use disorder treatment services that they need while they're still in custody, that there's a care plan that will help the individual transition out of the correctional facility setting back into the community and continuing to meet those individuals' needs in the community setting, so that we can reduce recidivism rates, we can increase access to services both while the individual's in custody and within the community setting as well, increasing care coordination across all of the systems that are providing services and support to justice impacted youth, as well as making sure that we're increasing the likelihood of better health outcomes for our juveniles and adults leaving correctional facility settings. We're reducing emergency department and crisis care and increasing community-based care to be able to better affect health outcomes for this population. Next. The CalAim Reentry Initiative is a larger kind of effort that includes the 90 days of pre-release services and the 1115 waiver, but it's a much broader strategy on part of the state to really think through a lot of the things that Will was talking about in the opening remarks about making sure folks are getting connected to whole person care supports, not just clinical care and supports, and that we're really thinking about the role of reentry and transition providers who are known, credible messengers, trusted partners with individuals with lived experience of incarceration, and that those are the people that we're really tapping into to provide these supports to individuals as they're leaving the carceral setting. The entire initiative is really made up of these components that you see on the slide before you, and really starts, starts with the idea that while the individual is incarcerated in a juvenile facility or in a county jail or a prison system, that there are infrastructure investments made to help the individual get enrolled into the Medi-Cal program if they're eligible for Medicaid or CHIP services. So that pre-release Medi-Cal application process is really part of that initial framework and setup that makes all of what comes next possible, because really identifying eligibility for individuals and helping them to complete a pre-release Medi-Cal application process will enable all of the services and supports to be implemented both while the individual's in custody and back transitioning into the community as well. the 1115 waiver that California received approval for in January of 2023 will enable those pre-release services to be provided for the 90 days prior to an individual's release back into the community. This includes physical health services, care management services, and mental health and substance use disorder services, including the provision of MAT treatment, medications for addiction treatment, as well as for medications to be provided for any physical health chronic conditions that the individual might be experiencing. So these 90 days of pre-release services are really meant to set the individual up for success, to get them started in stabilizing treatment, and to help with that transition and reentry care planning so that all of the individual's needs can be met by the community-based provider upon reentry. It also includes a significant linkage in terms of care management and behavioral health linkages. So behavioral health links and getting connected to county behavioral health agencies for individuals with a mental illness or with a substance use disorder, or for young people who have experienced trauma in their growing up, or because of their experience in juvenile hall or in a youth correctional detention facility, or for youth who may have adverse childhood experiences. We want to make sure that they get linked to appropriate behavioral health supports from our county behavioral health agencies or from our Medi-Cal managed care plans, whichever system is most appropriate to provide support, but really making those linkages to the behavioral health experts in the community. We also want to make sure that people are given access to intensive care management supports. And so all of the individuals who meet the criteria for the pre-release services for the waiver will also automatically be eligible for the enhanced care management benefit, which is a Medi-Cal managed care benefit that went live in July of 2022, but now includes justice-involved populations who are re-entering from carceral settings back into the community. The automatic approval for the ECM benefit. And really that even goes a step further, because with the enhanced care management benefit, we want to make sure that those ECM providers that'll be working with our Medi-Cal members in the community are connected to those members during that 90 days of pre-release services, so that there's a warm handoff between the correctional facility case manager and the ECM case manager, or the ECM case manager is going into the facility to provide those in-reach services. We also want to make sure that our people who are leaving incarceration are connected to appropriate community supports to meet their health-related social needs. So this could look like making sure that they're getting connected to housing navigation services or tenancy supports, or a whole host of other community supports that are offered by our Medi-Cal managed care plans. That does vary from county to county, since the community supports are optional for managed care plans to opt into, but most of them do offer all of the community supports that are most beneficial to our justice-involved population, including making sure that folks are getting connected to the housing supports that are available through that benefit program. And then, as Will was saying, and I said earlier, the justice-involved reentry and transition providers are really key to the success of these programs, to make sure that we have the right people who are providing the enhanced care management benefit. We have the right people who are supporting individuals and doing those wraparound supports through ECM or behavioral health links, that we're really engaging our community-based providers that are those with the lived expertise and experience working with this population. Next. For people to be eligible for the pre-release services, this really is for all Medi-Cal or CHIP eligible individuals who are in custody in a youth correctional facility, in a county jail, or in a prison system. I will note for our adult population, we did require as part of our waiver for adults to also meet healthcare need criteria, such as having a mental illness or a substance use disorder or a significant or chronic clinical condition, for example. But for all Medi-Cal and CHIP eligible youth incarcerated at a youth facility, or for those under the age of 21 who are incarcerated at an adult jail, or former foster youth under the age of 26 and incarcerated at an adult jail, those individuals do not need to meet any additional healthcare criteria and are automatically deemed eligible for the pre-release services, including that care management warm handoff, if they are Medicaid or CHIP eligible and enrolled in the program. Next. The pre-release services includes a wide array of services to help support the individual's transition from the carceral setting. And the foundation of those services is really about providing those intensive care management supports. The whole aim of this reentry demonstration initiative is to make sure that the individual is getting that support from their pre-release care team, that there's a warm handoff or connection made to the individuals who will be supporting them in the post-release community-based setting, and that those relationships can be built while the individual is still in custody. And so those care management services are really critical to the success, because it's really about establishing relationships with the individuals so that they will continue to engage in care in the community-based settings that is covered by our Medi-Cal managed care plans. But the services also include physical and behavioral health, clinical consultation, which is specifically treatment for specific health conditions, and that can be provided through telehealth or in-person in-reach services, or provided by the correctional facility staff as appropriate. This could include, completing a health risk assessment to identify any health or physical health conditions that may exist. Could also include the mental health and behavioral health screening that happens, as well as any treatment services that need to be provided while the individual is still in custody. And it includes laboratory and radiology services, medications, including medications for addiction treatment or MAT services, and the provision of services by a community health worker when a community-based community health worker comes into the facility to provide services through an in-reach model. And then finally, as part of the federal requirements for these waiver programs, correctional facilities are also required to ensure that individuals who are qualifying for this program receive covered outpatient prescribed medications for a minimum 30-day supply as clinically appropriate and approved within the Medicaid state plan. So that they're leaving the facility with their prescription in their hand, and they don't have to go to the pharmacy to pick up the medications, but they actually have it ready to go, as well as any durable medical equipment that's required upon release. Next. We have lots of folks involved in the reentry service delivery infrastructure. We have county and state correctional facilities. So our state prison system, our county jails, and our youth correctional facilities through our probation officers and the state, in every county in the state, are involved and engaged in doing this work. Our county behavioral health agencies play a key role, as well as community-based providers and community-based pharmacies, and our Medi-Cal managed care plans and ECM providers. So you see kind of the scope of each of these partners in the delivery of care in the continuum, or that puzzle piece that I outlined just a moment ago. But there are many folks involved that make this program, or will make this program, a success. Next. We know that there are still a lot of things that folks are wanting to learn about, and we get questions on a regular basis about how county jails and youth correctional facilities should deal with the fact that we don't always know when people are going to be released from county jails and youth correctional facilities, because the release dates are unknown at the time of booking or unpredictable, and folks might get out on a schedule that we weren't, that the county jail and youth correctional facility partners weren't, calculating for. We know that there's also questions about how to actually implement the behavioral health links and warm handoff, and what are the requirements around medication assisted treatment. We do have a pretty extensive policy and operations guide that is out and publicly posted on our website that gives a lot of guidance and direction in all of these areas. But we're also conducting a pretty extensive learning collaborative series for correctional facility and community-based partners so that they can get the answers to many of the questions that are top of mind through this learning collaborative series. And if you go to the next slide, it'll show you the timeline for when our correctional facility learning collaborative series will happen. And the next session is on September 26th. You can sign up through your correctional facility partners or through DHCS. There's also specific training and office hour sessions that are happening. But these sessions are really meant to do a deeper dive on all of those policy areas that folks want more information about how to go about implementing this initiative. So the next session will focus on behavioral health services, and then we'll go into discussions about non-behavioral health services on October 17th, and the enhanced care management benefit for the justice involved population, that warm handoff piece, how the linkages are going to be happening. This is the kind of timeline for our learning series that is upcoming. Next. Just a really quick overview of the Federal Consolidated Appropriations Act. In addition to the waiver opportunity that came about as a result of the Support Act through Congress, recently in December of 2022, Congress passed the Federal Consolidated Appropriations Act, which requires states to implement pre- and post-release case management and screening and diagnostic services for post-disposition youth in the 30 days prior to the youth's release from a correctional facility setting. There's also another provision which gives states the option to cover full scope Medicaid benefits for the pre-disposition population, and we're still assessing the implications for Section 51 2022 in terms of the timeline which we would roll this out. But you'll see on the next page, starting January 1st of 2025, it is required for the state to cover the 30 days prior to release for an individual. Of course, in California, through our waiver program, we are covering up to 90 days of pre-release services, but we're looking at the requirements that the Centers for Medicare and Medicaid Services issued through their state health operations letters, because there are additional requirements in terms of screening and diagnostic services that must be implemented for our youth who are in custody in youth correctional facilities, and making sure that all of those screening and diagnostic services meet the requirements of the early and periodic screening, diagnostic, and treatment, or EPSDT requirements in federal law. And so we're looking at that and we'll provide guidance to our youth correctional facilities, but wanted to make sure folks on this call are particularly tracking these requirements. And next page. And I think that's it. You see our email address here. If folks have questions following the webinar, we know that there's some questions in the chat, but you can email us at CalAim Justice Advisory Group, and I'll turn it back over to the web team now for next steps.
Thank you so much, Deputy Director Boylan. And there are a couple questions, and so I'll give you a chance to take a look at those. We'll have a few minutes for questions. Before we get to your questions, we have a couple questions for you. Yes, Ellen, we will get that email address dropped in the chat. While we do that, we have a couple questions for you. You will see another poll pop up on your screen in just a moment. We would love for you to just think about and reflect on the information that Deputy Director Boylan just shared, and just give us a sense of what the utility is of this information to your daily work and how likely you are to use it for your future planning. Give you a few moments to do that. Okay. Thank you so much for your responses. It looks like quite a few of you, more than half of you, give you a few more seconds, are finding that this information is useful or extremely useful, and almost everyone likely and very likely to, I should say about half of folks are very likely to use this information in your next step. So thank you for that. Autumn, I'm happy to call out a couple questions. You may have gotten a chance to scroll back, starting back with Jonathan Goldfinger, and I can put this slide back up. You had a question about the just not seeing county behavioral health plans referenced on that second slide. I'm happy to put it back up if you'd like.
Yeah, actually, county behavioral health agencies are very much involved as partners for the reentry demonstration initiative. And that's what the behavioral health links component of the waiver program is really all about. There's also state law passed that requires the county behavioral health agencies to go live with the behavioral health links requirements actually starting October 1st of this year. And so we've given some direction to our county behavioral health agency partners, but really it does require that coordination with the correctional facilities, both at the state level and at the local level, to make sure that people have been screened and identified as having a mental health or substance use disorder, that they're getting the link to the county behavioral health agency, that the county behavioral health agency is taking in the information. They're getting the data that they need, including medical records for the individual as necessary to continue treatment, and that they are primed and well positioned to continue treatment for the individuals as they're releasing back into the community. So that behavioral health links piece is also part of the pre-release set up to make sure that our young people, our adults in adult jails, and our folks exiting the prison system are able to get connected to county behavioral health agencies for special and mental health services, drug medical services, or drug medical organized delivery system services as applicable and appropriate. The managed care plans also do have a role in providing mental health treatment to their enrolled members. And so part of, the goal will be for the correctional facility to identify whether they would meet the specialty mental health services criteria or if the referral should be made back to the managed care plan. But they absolutely do have a role in terms of the reentry demonstration, and we're working very closely with them.
Awesome. Thank you so much. Just to help kind of tee up, because there's several comments and chats. I believe that Ernesto Rodriguez's question has probably been answered in the chat, but Ernesto, just chat us back if you want some follow-up there. In the meantime, I think if you can see Christopher Middleton's question, he has a question about eligibility for pre-release services.
For Christopher Middleton?
Yes, I can call it out because it's a little bit further up. It says, oh, you see it?
I think I see it. So it says, for adults, can eligibility for pre-release services be met via an undiagnosed mental illness, or is a prior formal diagnosis needed? I would say, I think the answer to your question, your first part of your question, is yes. It is not necessary for the individual to have been previously diagnosed. As a matter of fact, we would want to make sure that the correctional facility is conducting screenings and doing assessments of individuals' mental health needs, so that if there is an undiagnosed mental illness, that is being captured through the screening process, and then appropriate treatment can be delivered to the individual while they're in the carceral setting.
Thank you. And then Christopher, if you have any follow-ups, feel free to chat there. Timothy has a question, and I'll just give brief context. He wrote this when you were on the slide about top 10 policy operational issues, and asked about post-release ECM and wondered, can ECM become involved prior to release? And if so, are there any restrictions?
So we do want the ECM providers to be involved in the transition planning and reentry plan as part of that warm handoff. So the idea is that while the individual is still in custody, the pre-release care manager, if that is a care manager that is embedded within the correctional facility, is actually making the connection to the community-based ECM provider, and that warm handoff, the introduction to the member, all of those things are happening while the individual is still in custody. The ECM providers can bill for these services as fee-for-service providers, but would need to be enrolled in Medi-Cal fee-for-service to be able to provide those services, or would need to have a contract with the correctional facility to be able to provide the services in the pre-release environment. And so there are some steps that our ECM providers would need to take take, but that's the idea. And even more ideally, we would want those ECM providers to be in-reach providers, where they're the ones who are actually responsible for the pre-release case management and just carrying that through to release back into the community for the individual.
Thanks, Autumn. It looks like Jonathan had the same question as Christopher, but Jonathan, if you have other follow-ups, feel free to chat those. Kimberly had a follow-up to, I think, the previous question about screenings and enrollment being part of parole probation stipulation. Can they? Was her question. Kimberly Gutierrez.
I don't think that, I mean, I think from the Medi-Cal perspective, all of the services are voluntary. And so we would want to make sure that folks are getting access to, the screening and treatment services that they agree to. We're not asking correctional facilities to stipulate parole and probation conditions based on the CalAim initiative. I think that's the question that is being asked there, but.
And we'll have time for one more. And I don't believe Laura's questions have been addressed yet. But Laura from Next Step says that her organization works with youth very closely post-custody, and that youth leaving custody need more support than they have to take advantage of resources. She's referencing the warm handoff that you spoke about. And so she said, without that, resources really aren't accessible, and is curious about how they can partner.
Yeah, absolutely agree that that kind of warm handoff piece is really the key to the success, and making sure that the handoff is happening to community-based providers with lived experience and expertise to actually engage with the individual, and that somebody that is a credible messenger for the individual as they're leaving custody is super important. So there are lots of ways that folks can get involved as ECM providers. We have a TA marketplace for our community-based providers who are interested in becoming ECM providers across the state. So there's lots of resources available for folks interested in learning about how to become a Medi-Cal provider to provide the ECM services. And you can also email us at the CalAim Justice Advisory Group email address, and we can get you connected. But I'll put the link to the TA marketplace also in the chat, so folks are tracking those resources that are available now.
Thank you so much, Deputy Director Boylan. And just so you all know, we're going to send a follow-up email. We'll be sharing lots of information in the chat, so don't worry if you're not able to catch all of it here. We'll be sending a follow-up email with all the resources and links after the webinar. So thanks again so much. And we are going to move to our next segment. I'd love to welcome Dr. Sohail Sood to join us. He's going to be giving, Dr. Sohail Sood is the director of CYBHI. He'll be giving an overview of the initiative and introduce two guest speakers who will share more about projects operating within the initiative. Dr. Sood?
Thank you so much, Tara, and good to be with all of you. I'm really honored to be here. As was just mentioned, I direct an initiative really intended to support the well-being of young people across the state. It's called the Children and Youth Behavioral Health Initiative, and the goal is really to transform the landscape of behavioral health services that are offered. So that includes really expanding services provided in the healthcare sector in significant ways. We are breaking ground on new facilities. We are expanding training programs so that there's more providers in the state, including social workers and psychiatrists. And we're providing incentives so that they serve the geographic areas with greater need. We're standing up a new workforce called a certified wellness coach that is really intended to serve as an entry-level behavioral health specialist. And we're establishing a statewide consultation service so that any outpatient clinician taking care of a young person, including those working, perhaps some of you working in the justice system, so that these clinicians can obtain advice from a specialist. You can speak to a child psychiatrist, you can speak to psychologists, instead of condemning them to long wait queues to be seen. So questions about diagnosis or medications or therapeutic options can be addressed in near real time. So happy to talk more about all that. But I think you'd agree that if we just fix the healthcare sector, it'd be important, but it's not enough. So when talking about improving wellness and resilience and behavioral health, and more generally our societal response to a young person in stress, the answer can't just be to wait for them to connect to a provider. It's too hard in many cases, and in other cases, it's too late. Will Lightbourne really alluded to this in his poignant opening remarks, and I'll just add that our goal here is to support families and children and youth in the places and spaces where lives are lived. And so with that in mind, this initiative is also building up services to reach homes, to reach communities, to reach schools that provide support online. That's what the youth told us. And to do all of this with an orientation to prevention, to self-determination, and a strong focus on equity, with equity including support specifically for this community. So in a moment, you're going to hear from two of my fantastic colleagues, Dr. Sharmil Shah from the California Department of Healthcare Access and Information is going to share more about a new training that's being developed for all the adults who work in the system. Not just the specialists or the therapists, but really everyone who interacts with the youth in the justice system. Because it really behooves us all to learn how to engage effectively and therapeutically. It takes skills, not just heart. Heart's important, but we're also here to learn some skills here. And after that, you'll hear from Dr. Tully, who's Vice President of Partnerships at Kooth, who will spend a few moments sharing out resources that allow any young person with a smartphone and an internet connection to connect to a coach to help them through whatever they might be going through, whether that's drama at home or some stress or trauma they just witnessed, or something going on in any other setting, relationships, school, what have you. It's called Saluna, and it's really for all Californians ages 13 to 25 years old. No cost, no judgment, no insurance needed. And then I'll also mention that this month, as you know, is Suicide Prevention Awareness Month. And we have a campaign going on, not just during this month, but throughout the entire year, called Never a Bother. And I'll put a link into the chat around that. That was created by young people ages 16 to 25 for young people. And if you go to the website, you'll see messages from real Californian youth who've come through some tough times and have some important messages to share. Things like, what are some of the warning signs of suicide that we should all know about? Or what's the best way to have a conversation with a friend or a young person who's coming to you in need of some help? And what is it actually like when you call the Suicide and Crisis Lifeline at 988? Who picks up on the other end of the phone, and what do those services and supports look like? So if those topics are of interest to you, or you'd like your staff or the young people in your care to hear more about it, please check out the website, contact us, let me know if you want materials in your facilities. This campaign is all about raising awareness and education to really weave in that fabric of support. Also at the Youth Justice Action Summit occurring this November, we will go deeper into some of the supports that are being built out for schools, which include court and community schools. So just a plug for those interested to hear more about it over there. You all know this, but I'll just close by acknowledging the relationship between mental health and substance use and involvement in the justice system. It's complicated. So I'm just so appreciative for everything you do to support young people in what is clearly a stressful time during their life. And if there's anything I can do to support, don't hesitate to reach out. So with that, I will pass over to my colleague, Dr. Shah, to share a little bit more about some of the training specifically for many of you out there. Thank you.
All righty. Thank you, Dr. Sood. Hello, good afternoon, everyone. As mentioned, Sharmil Shah, Assistant Deputy Director for the Office of Health Workforce Development, and thanks again for the opportunity to share about a very exciting HCI program that is addressing our at-risk youth. I think if we can move the slide, there we go. All right, thank you so much. So with any program, usually a program starts with some problem that we're trying to solve. And I don't need to tell any of you that research points to a very significant overrepresentation of youth with mental health disorders that are in our juvenile justice system and foster care systems. And in addition to that, there's also this increasing need for programs that address mental health issues of youth at risk for homelessness. But despite this reality, there is a low availability of prevention and early intervention mental health services within our system to address these issues. And so, next slide, please. And with our partners at the Catalyst Center and in collaboration with the California Association of Alcohol and Drug Program Executives, CADP, and the National Council of Mental Wellness, this group will provide trainings aimed at increasing non-behavioral health and non-medical professionals who regularly interact with at-risk youth. And this program is called the Justice System Involved Youth Substance Use Disorder Behavioral Health Training, or JSIY, if many of you may have heard that acronym. The best way to explain this program is to kind of give you a tour of the website that is just now. Let me see if I can share my screen. Thank you, Tara. Let me do that quickly here. That is fairly new. It is just kind of getting off the ground. So there are some parts of this site that are not entirely built out, but wanted to give you guys a preview so that you could kind of see what this program is about and how you can get more information if you wanted to. So this is our home site, the home page. The link that was in the slide takes you to this training homepage, and this site states its mission: to offer training for adults to build authentic connections with justice system involved youth and those with substance use disorders. The program equips participants with skills to engage youth, reduce stigma, and identify needs, fostering trust and resilience to support the well-being and recovery. All buttons on this page will take you to a functioning interest form where you can sign up to be notified of further developments. Looking at the links here at the top, like Get Trained, Become a Trainer, News and Resources, I'm going to walk you through a couple of those. In the Get Trained, looking at it's got a drop down of training information, training schedules, and some modules, which is coming soon. But if we were to look at the training information page, this is where you will learn, and it's begin testing in the fall of this year, where this program is meant for adults without medical backgrounds who interact with at-risk youth. The training focuses on practical skills for engaging youth, destigmatizing conversations, and connecting them with appropriate supports. It aims to serve all communities across California with input from a diverse advisory board and focus groups, ensuring that this curriculum represents and supports marginalized and underserved populations. The buttons here will also take you to the interest form. In Become a Trainer, this is where they will feature the Train the Trainer program. It empowers individuals and organizations committed to expanding the program's reach in California beyond what the core training offers, and longevity beyond this partnership. Participants will learn to share the curriculum with their communities and organizations, and no medical or behavioral health degree is required, but strong connections with both youth and adults are essential. If we look at our news and resources, we can select referral resources. And here they will have all the kind of resources that people can click on to get help right away. So the National Council for Mental Wellbeing, SAMHSA, 988, California Coalition for Youth, the National Domestic Violence Hotline, the Trevor Project. You can see all of the Suicide Prevention Hotline. We also have there's also a very unique page about compassionate support materials. This is a very important page as it aims to reduce stigma. So this emphasizes the importance of that stigma-free environment for individuals facing substance use and behavioral health challenges. It's helpful as it has information on how negative beliefs and language can prevent people from seeking help, and encourages the use of people-first language to foster respect and empowerment. This page advocates for understanding recovery stories and sharing affirming messages to promote a supportive culture. So those are the kinds of things that you'll be able to find on this page as it gets more built out. The last link I wanted to share about is the About, so About Us. Here is where we have credited the organizations that were involved in implementing this project. So those include HCI, the National Council for Mental Wellbeing, Catalyst Center, and CADP, which is the California Association of Alcohol and Drug Program Executives. Now, if we can go back, and I'm going to stop sharing here, and if Tara, you can go back to that last slide, there is an opportunity for all of you to test the program. And sorry, the third slide, sorry, the one right before this, I think. Yeah, this one right here. So those interested in helping to test the course are encouraged to apply. So this basically takes you, let me see if we can click on that. Tara, I'm sorry, for some reason I can't click on it. This bottom one, the open door beta. Yeah, that's it. We're running a beta test, and it's kind of an up. Let's see, does it go into that? This one, yeah. Should take you to an interest page. And this is where you can input your information. And let me see.
Pull it up on this side. It did
Yeah,
not
sorry
respond to
about
my clicking, so I'm just typing it in, but it should be this one right here. Does that look right?
Yep, that's it. Perfect.
Okay,
Thank you so
sure.
much.
Of course.
And so this is what the Open Doors Training Beta Testing Interest Form looks like. So if you're interested in supporting us, providing your feedback, kind of testing the site, testing the programs within the site, we'd really encourage you to sign up through this interest form. And then before I close, I just wanted to see, I have a colleague online who was very much involved deeply in the development of this program with our partners, and wanted to see if she had anything else to add regarding the JSIY program. Ann Powell, did you have anything else that you wanted to add?
Hi, Sharma. I would just emphasize that this is for any staff without the behavioral health background who work in any setting that serves children and youth, and that the goal is to prevent the onset of conditions by having a good well-trained person who doesn't have to become a clinician, but can help field the needs of a child and get them connected with necessary services as appropriate. So I would just add that to what Dr. Shaw has already presented. Thank you.
Thank you, Ann. So that concludes this presentation for the program. We're welcome to any questions that you may have. Oh, let's see, I'm already starting to see some. Tara, when I just jumped on, you may have had a protocol.
Sure. Yeah,
question.
no, it's fine. It's fine. It's fine. We actually were doing great on time, so we can take a couple now, and then after Dr. Tully presents, we can take some more if there are others. Looks like Jonathan Goldfinger has a question, and the others, I think everything else is prior chat. So he has a few. If you have time, maybe we can take the first couple, and we can come back to the others afterwards.
Yeah, that sounds good. Let's see. Anne, this looks like, this one looks like for you. Will this training certify them as the new wellness coach?
Will not. The wellness coach certification still requires that an individual get the appropriate associate or bachelor degree in order to secure certification as a wellness coach. But this is important experience for this workforce to figure out if they want to begin working in this direction. They may, in fact, already have a degree, and we would encourage them, if they do, to go ahead and reach out to us for certification.
Thank you, Anne. I think number 2, Sohail, is Dr. Sood is for you, I think.
Yeah,
I'm
happy to take that. That work is also being done with support from the Department of Healthcare Services, and Autumn Boylan has many hats, including CalAim and parts of CYBHI. So you're welcome to jump in on the question, but just to read it out loud, will that statewide consultation service that I mentioned, so it's called CalMap, will it be available for ECM lead care managers, wellness coaches, CHWs, and peer support specialists to speak to a psychiatrist? Go ahead, Autumn, if you'd like. Otherwise, I can jump in too.
Yeah, so right now the program is aimed to provide consultation support services to physicians, include and physician care teams, so nurse practitioners, physician assistants, for example, and to clinic settings. I think we are thinking about, how the CalMAP program could support programs at large, including non-clinical programs, to better understand the appropriate care options for young people who are, receiving treatment from different types of community-based providers or school-based settings. But for the initial launch, we're focusing on expanding access to outpatient physicians, primary care providers, pediatricians, and our physician clinics.
Thank you. Yeah, I'll just add, if you think it's fair, that a lot of the provider types that you mentioned there work closely with care teams in multidisciplinary fashions and often under the license and supervision of other providers. And so if you think of that care team as a whole being able to access these services, and in many cases that may end up being the case with the kind of considerations that Autumn has just alluded to.
For sure.
I see there's a question, Dr. Sood, about HIPAA. Yeah.
Yeah. So for this service, and we'll put the link in the chat, and we can come back and talk much more about it because we welcome that opportunity. It is all done through HIPAA certified providers and platforms and arrangements that will ensure that the transmission of information of any kind is done in a secure manner. And I think with that, perhaps we can transition to Dr. Tully to talk about really a service that's available for all of our youth to access some services and supports online.
Thank you.
Mhm.
Thank you. And I should be sharing my slides. Hopefully everyone can see them. Looking for a nod. Okay, I saw a nod. Thank you. Good afternoon, everyone. Thank you very much for inviting me to be here. I'm delighted to talk to you about the platform Soluna, powered by CUF. That's the company that I work for, and we have partnered with the Department of Healthcare Services as part of the CYBHI program to provide free mental health support to every Californian youth aged 13 to 25. So first, I want to tell you a little bit about who CUF is, just to give you some context. The company was born at a kitchen table, quite literally, in the UK in 2001, with the idea of transforming youth mental health. It was put together by a counselor and an internet enthusiast who thought that the internet was going to be a big thing and that young people would probably like to use it. And since then, CUF has become the #1 digital mental health provider for UK youth. So we have 20 years of digital mental health expertise with over 50 research reports that we've collaborated on with 10 or more academic partners. We've provided service to over 1 million individuals and over 1 million hours of support to those individuals. And based on our data, we know that 74% of individuals that use CUF and our platform achieve positive change towards their life goals, and 72% of them meet at least one need in a single session. And I'll talk a little bit about our single session model in a second. A bit more information about our approach. So we are a true prevention and early intervention approach, which fits very nicely with the CYBHI goals and values. The idea here is that we're catching young people upstream before they need more acute or regular outpatient services, and positioning the platform as a digital front door to mental health support. So it's often, for a large majority of our young people who come to us, it's the first touch point they've had with the mental health system. And as I'll talk about in a minute, we have an anonymous model which allows a sort of safe, stigma-free, non-judgmental space to start exploring questions that you have before you might choose to move downstream in the system. We focus on goal-based outcomes rather than symptom-based outcomes. So it's very person-centered, it's strength-based, it's rooted in self-determination theory. And the goal here is to support young people in achieving outcomes that matter to them and to build the life that they want to live. And it might be that symptoms are getting in the way of that goal, but it might be that something else is getting in the way of that goal, like they need a library card or they need social support in figuring out how to ask that person out on a date. So it's very focused on how that young person builds the life they want to live. And finally, something that I'm really proud of as a former director of training and a clinical psychologist myself, CUTH has committed its 20 years of work to creating a standardized process to provide consistent, high-quality service at scale. So one of the advantages of providing coaching and mental health support in a digital space versus traditional brick and mortar spaces is that you can review and audit every single interaction with a service user. And what we do is we conduct quarterly audits of our practitioners using our clinical model called iRespond, which you can see here on the right. So every single one of our coaches and practitioners are evaluated against this model to make sure that the care that they're providing is integrative, responsive, evidence-based, safe, person-focused, outcomes-driven, non-judgmental, and data-driven. And this is quite unusual in traditional mental health care, partly because we have a lot of different types of training programs feeding into the workforce that have different kinds of quality control metrics, and partly because it's very hard to get visibility into every single touch point in a brick and mortar space. So this is one of those advantages of digital implementations that CUTH has really leveraged. So now you know who CUTH is, let me tell you a little bit about Soluna. And as I said, this is the platform that provides free mental health support for all California youth aged 13 to 25. It was officially launched statewide in January 2024, so we're in our 9th month. And I've got some very early data that I can share with you in a couple of minutes. So Soluna was developed with a lot of community input. It was designed for young people, by young people, and was a big part of the efforts that DHCS made to get community voices involved. So it's funded as part of the Children and Youth Behavioral Health Initiative, as Dr. Sood was describing. Input from over 500 organizations, state agencies, CBOs, et cetera, was taken to drive CYBHI. And then the particular work stream that we're in, the Behavioral Health Virtual Services Platform work stream, we had over 50 California youth and a large group of behavioral health experts engaging in think tank sessions and focus groups, so that we were making sure that we were going to be designing platforms that made sense for the people that were going to use them and for the system that it was going to integrate into. When we got down to the nitty-gritty of building Soluna, we co-designed it with over 300 young people, and we continue to iterate on that design by gathering input and co-design support from our youth advisory panel. It really is important for us to recognize that a bunch of middle-aged people should not be making the decisions on what a mental health support platform looks like or feels like for teenagers and young people. They need to be involved in it, really taking that principle of nothing about us without us, and bringing the young voice in. So with that, this is what Soluna looks like very briefly. And we've taken the approach that we've been using in the UK and adapted it based on our youth input. There are 3 ways that a young person can get support through Soluna. Right now, Soluna is accessible through a smartphone app. By the end of September, we will also have a live web version. And by the end of 2024, it will also be tablet compatible. And so we'll have cross-platform compatibility. The first way that they can get support is through self-guided resources and coping skills. So we have a selection of informational articles, journaling, mood logs, breathing exercises, and other such things that a young person can navigate based on what they're interested in, what questions they have, and what kinds of supports they might want as they navigate the challenges of their daily life. The second way young people can get support through Soluna is via our community forum, where they can get peer-to-peer support from other service users on the platform, so other people like themselves. This is a pre-moderated forum so that we are creating a safe, stigma-free space. And I'll talk a little bit about how we handle safety in a second. But what I like to say about this is we've taken all the good stuff that social media or the internet offers young people, which is community and connectedness and information, and we've left all of the bad stuff like bullying, inappropriate content, hate speech, etc., and created this safe space for them to communicate with each other about questions they might have. The third and final way they can reach support through Soluna is our behavioral health coaching feature. So this is either in-app chat coaching or video coaching, or can also be done by phone. The coaching doesn't require an appointment at all. It's almost immediate. The latest data statistic that my team shared with me is that the average wait time for coaching is about 90 seconds. So it really is in the moment coaching. Coaching is available from 10 a.m. to 9 p.m. Pacific. I will just add a little asterisk. 9 p.m. is the last moment of entry, but your coaching session can go through 10 p.m. Young people can also schedule coaching if they want to with a particular coach. Our coaching team is made up of probably about 2/3 is certified peer support specialists. So these are individuals with lived experience of mental health challenges and other challenges that society might have thrown at them. And a young person can pick a coach to work with based on certain lived experiences or identities that might be of interest to them. So if they want to work with someone from the LGBTQ community, they can find somebody there. If they want to work with someone with lived experience of homelessness, they can find somebody there and talk to them about similar experiences. The remaining third of our practitioners are a mixture of folks with substance use expertise, general behavioral health practitioners, and of course, our licensed behavioral health team who do all the things that licensed people do, like supervision and safety management and training. We also have a care navigation feature, which is our concierge service that connects service users to community supports outside of Soluna. They conduct a brief needs assessment. They'll work with the young person to remove barriers. We can submit referrals on that individual's request, and we'll conduct warm handoffs. And I really mean warm handoffs. We walk side by side with the young person and really make sure they land where they need to land, rather than just kind of handing them a list of phone numbers to call or some websites to look at. Just very quickly, I want to talk about safety. So coming back to that community peer forum where service users can submit questions or comments in response to other service users' questions to either get support or provide support. Every single one of those posts that are submitted, so all user-generated content, is pre-moderated before going live on the platform. And what that means is it is seen by a human and evaluated against our community guidelines to make sure that it doesn't have any inappropriate content, bullying, hate speech, etc., but also that it doesn't have any signs, any information that could identify that young person. So no personal identifying information, since anonymity is a really important part of the platform. And finally, we also have risk flagging for those posts, so that if an individual is expressing signs of risk like suicidal ideation, that is flagged, and a member of our team then works with that young person to choose the best path to keep them safe. The anonymous model protects service user identity. We have robust safeguarding policies for risk management to keep young people safe when they are experiencing suicidal ideation or similar. And importantly, the service users on the app, they're not able to direct message each other kind of privately. They can only interact with each other in this public forum space where everything is pre-moderated. And so there's no possibility for inappropriate content or interactions. There are 3 ways people can integrate this. There's pre-appointment support, so it can be a resource and a companion in the young person's pocket while they wait for an appointment. It can be a treatment companion where they can use it for skills practice and after-hours support and community and connectedness. And it can be part of discharge planning and booster support when someone is graduating from a program or transitioning to a new one. I'm realizing that I ought to do a time check. Tara, how am I?
We should wrap up and give just a couple minutes for questions, but feel free to wrap up and take another minute.
Thank you for the extra minute. I want to just show you some of this early data, which is really exciting, and then I'll stop. So what we know from our early data is that Soluna is being used statewide, and it is reaching underserved communities, which is one of our primary goals. It's being used in all 58 counties, and about half of our users are present in underserved communities as rated by the HPI index. You can see that over 50% of our sessions are happening outside of 9 to 5 hours, which really just tells us how much there is a need for after hours support. And as I mentioned, we've got less than 90 seconds wait for a coach. And our service users love the coaching and find it extremely helpful, as you can see by these very high percentage ratings for feeling heard, having at least one need met, and giving positive feedback. And I'll just leave this up on the screen while I open things up for questions. I think these testimonials from our users are really powerful, and it tells you just how important a platform like Soluna is for supporting young people with their needs. And I will stop there and listen to
Thank you
questions.
so much. Yeah, thank you, Dr. Tully. Super innovative and exciting. There's one question already in the chat, and while you process that question, which we'll come to in just a second, we have a question for you all, the audience, give you a chance to catch your breath. Same question, different topics, and thank you again, Dr. Su, Dr. Shah, and Dr. Tully for such informative and useful information. We would love to hear from you just how this information resonates with all of you. As participants today, you'll see a poll showing up again, same questions, utility of this information to your daily work, and the likelihood that you'll use this information, both about the Soluna app and about the training. We'd like to get your feedback on both of those. And then Dr. Tully, whenever you would like to, as people take the poll, feel free to jump in. There's a question from Jonathan Goldfinger, and I don't think there's any above that, but whenever you're ready, you can feel free to address that aloud.
Thank you. There was one, I think, that was asking about Soluna being bilingual.
Thank you.
It is available in both English and Spanish as an entire platform. And then phone coaching is available in all of the Medi-Cal threshold languages. I think there are 19 of them, including English and Spanish. And then I'm scrolling, hold please. The concierge navigation service. It is an internal service that we have where we have like care coordinators who will then interact with community supports and care supports outside of Soluna. And so in that case, what would be happening is our care coordinators would be reaching out. First, they do the needs assessment with the young person. They also evaluate that young person's resources, insurance, no insurance, etc. And then they identify in the community what resources match both their needs and their eligibility, and then work with that community resource to get that young person connected. And like I said, that could include submitting referrals or talking to the CBO or provider and figuring out how to get them in for supports. If you are interested in creating a really smooth connection between the Soluna care navigation team and your provider program, we are also building out our affiliate network, which is essentially partnerships with providers in the community so that we can do smooth referrals, digital referrals through our database and repository of community services and programs. And if you are interested in that, please do email me and I'll connect you with our care navigation team. You don't have to be in the affiliate network to be part of how our care coordinators might connect young people to you, but it smooths everything and has some advantages on both ends in terms of communication between providers and care coordination.
And Dr. Tully, just two more and then we'll move to our next segment. One that I got via direct message was just about the availability of the Soluna app to youth. So youth on probation and facilities, what's the availability for youth justice population?
Great question. So I think the short answer is any Californian youth that falls in the age range of 13 to 25 and has an internet-enabled app-enabled smartphone at this time has access to Soluna. So of course, young people in YDF or similar detention facilities likely have limitations on their access to the internet and mostly do not have their devices. So right now we do not have a solution for that. As I mentioned, at the end of September, we will have our web-enabled version of it. And so there are ways that we could problem solve access for folks that do not have personal cell devices by using that web-enabled platform. And of course, we would have to solve that within the parameters of the facility that is housing those youth. Because again, they tend to have pretty strict rules around internet access and device access. So short answer is, if you're not currently in a facility under detention where you have limits to a smartphone, you have access to it.
And last one, Dr. Tully, if you don't mind responding to in the chat, we'll move to our next segment. April Yee, just a little scroll up, has a great question about removing barriers, a clarification for that. But we'll, if you don't mind responding to that in the chat, we'll keep it moving.
Absolutely.
Thank you so much. Thanks so much, all of you. All right. Thank you also all for your feedback on the utility of the information we have so far. We're going to move to our next speaker, Alex Briscoe, who's many of you have already met. He's been active in the chat, and he will talk about navigating the current unprecedented reform landscape. So Alex, I'll turn it to you.
Thanks, y'all. I'm hoping everybody can see my screen. Thank you, Tara. And the fact that there's still 100 and some people here, thank you, because we just threw a lot at you. And I once had a mentor say, we have the most complicated descriptions for the things we understand the least. So it can be really hard to hold and understand what's happening, but it's really big. And I'm going to take a shot at trying to sift and sort it for you if you're working with system-involved kids. So in 10 minutes or so, I'm going to teach you how Medicaid works, what new things are happening, and hopefully give you some tips about how to go get it. So unfortunately, we are living in a moment where suicide has surpassed cancer as a cause of death for children. And we've also seen a doubling of inpatient admissions for self-injury, a 50% increase in pediatric bed days, a 61% increase in the rate of self-reported mental health needs. And we've now gotten to this unfortunate place where 42% of young people have experienced persistent feelings of sadness and hopelessness. And 1 in 4 young people have seriously considered committing suicide. And in California, while we have increased eligibility to Medicaid, we're almost at half of all kids are eligible. A 30% increase over the last 7 years, excuse me. And this means that you're eligible for Medicaid if you live in a family that makes less than 268% of federal poverty. Think like 60 to 70 grand for a family of 4. Remember, you can have adults, their eligibility line is 138%. So you have lots of kids living in families where the parents are not on Medi-Cal, but the kids are. And I'm very proud to live in a state where we now do not discriminate on access to Medi-Cal based on immigration status. So as of January, when we added the 26 to 50s, everybody in California who meets these income guidelines are eligible for Medi-Cal. But it is not news to anyone here that we're struggling, meaning that less than 6% of the almost 5 million children on Medi-Cal get access to anything at all. And only 3% are in ongoing care as measured by 5 or more visits in a year. And if you don't disaggregate this data by race, you're missing the point. It is fair to say that many young people receive the wrong care at the wrong time, and unfortunately, and too frequently, in restrictive and punitive settings. 81% of kids on Medi-Cal are children of color. About 70% of licensed clinicians are white. And I like white people. We're cool. We got something to offer. But as Will explained, there is 50 years of evidence that shows that when the treating professional shares your lived experience, outcomes are always better. Black kids kill each other, try to kill themselves more than white kids. And we know that somewhere around 80% of youth living in California's juvenile justice system have unmet behavioral health needs. I didn't mention this, but I come to this work having been a therapist in the Oakland Public Schools, leading an emergency department. And then I ran one of California's largest public health systems, where we ran a juvenile hall with, started out with over 470 young people in it. So making healing-centered systems requires an acknowledgement of how racism and poverty are impacting the social and emotional health of children. And I'm not just saying this because the critique is not the strategy. The stuff that Autumn and Soheil talked about was an attempt for Medi-Cal to actually take these lessons in and reflect them and how things are paid for. And so for you to understand all of the things that we talked about today, it is real. Something really is happening because there's political will like there's never been before. At the state and federal level, we are talking about behavioral health in young people in ways we never have before. Californians say this is among the most important thing to them. And we're finally, and frankly, in many ways, through the extraordinary leadership of Dr. Nadine Burke-Harris, we are finally developed a language to name the fact that it is not pathology that is driving these really hard data. It's adversity. Meaning you can't explain the numbers I started talking to you about simply in the context of the medical model. And look, it's easier to do it with money than without. The Youth Behavioral Health Initiative is over $4 billion. Community schools and many other investments that the state is making. We're spending $10+ billion on trying to address the hard, harsh reality that it's a uniquely difficult time to be young in America. But to take advantage of these investments and this emerging consciousness and the reality of the crisis, you have to learn who the managed care plans are. Like, just get down and dirty with it for a second. If you're a juvenile justice stakeholder, you may not know the name of the managed care plan that serves the young people who live in your county, and you have to learn who they are because they're the new center of the universe. We have to change how we pay and do, so how we finance and deliver, so that things happen in teams, meaning the idea that every kid needs a 50-minute psychotherapy session is broken. The future of mental health is a therapist working with a team of CHWs or credible messengers, managing a panel or a group or hundreds of young people at a time. And I will dive into this, but we need to reimagine who does the work, meaning focusing on a healthcare system for people, by people. This includes the new provider types that you've heard referenced today, but also the work of lay people and subclinical supports like Kuth. And if I spontaneously combust and you take nothing else from what I've said, I hope you can hold with me this idea that all of us have to free ourselves from the bonds of the medical model, the chains. Mental health is a support for healthy development in an increasingly toxic culture. It is not simply a response to pathology. There is mental illness. I have billed hundreds of millions of dollars of mental health services to Medicaid. About 20% of the kids I served were actually mentally ill. About 80% were sleeping in a car, told they weren't worth nothing, or other bad stuff had happened to them. And why Medicaid is so important to you as juvenile justice stakeholders is every child serving system in California works this way. There's a federal law tied to a state action, but it's administered at the local level. This is true of education, of early childhood, of child welfare, of juvenile justice, of the regional center. Medicaid is the tie that binds these systems together. The way we will transform public education, the way we will decrease reliance on congregate care and foster care, the way we will disrupt the prison pipeline is by healing-centered strategies, and the financier of those strategies are Medicaid. And I say this not just as an advocate. I say this having used these tools directly and specifically over 25 years of experience in Alameda County. We reduced the number of children in detention from 484 to 34. We reduced the number of children in out-of-home placement and foster care from 6,200 to 1,200. And we started 240 programs in schools that serve 65,000 children annually, all of it funded by Medicaid. And why Medicaid is so important is it has a role for preventing children and families from ever needing child serving systems to begin with, because almost all families that interact with juvenile justice and foster care are poor, meaning they qualify for Medicaid. Then once families touch systems, we need to give them all sorts of supports. And then once kids are in our systems, we need to give them much more than what they're getting. So think of Medicaid having this application as a tool for prevention, a tool for first contact and redirection, and then for young people who unfortunately end up in these systems, how to improve their experience for them and their family. So it's not just one place, it's this continuum that Medicaid can change our experience. And young people in Medicaid up to the age of 21 have a unique status. They have very broad eligibility. They don't have to be sick to access care. And the state of California has led the nation in removing diagnosis as a prerequisite for care. You no longer must meet specific DSM diagnostic criteria to access the mental health system in California. They also have a unique financial standing, meaning every dollar you spend on a kid in Medicaid must be matched by the feds. And that's really important for you in the juvenile justice space because you're spending a lot of the kinds of dollars that could get matched if you learn how to partner with Medicaid, in particular your county mental health systems. So this is how every Medicaid expenditure works. Literally every one has a state share or a non-federal share plus a federal share. So the way to think of Medicaid is it's like a pot of gold in DC. You put up a dollar to get a dollar or some other ratio. Literally every expenditure has these two parts. The non-federal part has a fancy name called a CPE, and the federal part is often referred to as federal financial participation. But this is how it works. Seems pretty simple, right? Like how has it become so complex? Well, let's track that federal dollar through the state of California and talk about how it shows up in the lives of children and families. The first and biggest way is through the managed care plans. And that's where I have found juvenile justice stakeholders have the least experience of connecting with Medicaid. Some connect a little bit through their county mental health department, but very few have experience getting money from managed care plans. So that's the biggest, actually the biggest, deepest pocket in Medicaid are the plans. Then the county mental health departments, school districts and community health centers, public health departments, public hospitals, and the regional center. The Regional Center for Developmental Disability is also a Medicaid program. It's actually a 1915 waiver itself. But this is the architecture of our failure, meaning when everyone is responsible, nobody is. And one of the important things to hold about CalAim is the opportunity to coordinate care centrally through the managed care plans. This is really important, that the state is making a significant and massive investment in trying to build a care coordination infrastructure that represents a massive and important opportunity for juvenile justice stakeholders. But the mental health system remains bifurcated. And so if you've heard these terms before, or you've heard versions of them, I want to clarify what they mean. Meaning in California, if you're on Medi-Cal, you are eligible for mental health services from your county, the specialty mental health system, but also the managed care plans, the non-specialty mental health system. And the right one is the one that pays, okay? Just to get, practical. Some counties have incredibly robust specialty mental health systems that work really well with their juvenile justice systems, others not so much. So understanding this bifurcated mental health system is really important, because if one doesn't work for you, you need to be able to go to the other. So there's hope for this system, and it comes from Medicaid reform. And you heard about the architecture of that reform from Autumn and from Sohio. By making a few essential changes to Medicaid, we can break the chains of the medical model and transform the experience of children and families. And these changes are the changes that are happening in California. First, we can remove diagnosis as a prerequisite for care. You shouldn't have to have a diagnosis. If you're hurting and need support and help, you should be able to get it. We have to reimagine the workforce and the model, dramatically expanding who can do the care and where it happens. We need to treat parents with their kids. This is a very specific strategy tied to little children and their caregivers. Low-income families go to the doctor the most frequently in the first 3 years of their life. But babies don't go to the doctors by themselves. But when caregivers bring their baby to the doctor, they are invisible to Medicaid because the baby is the identified patient. And the state has created a new benefit in Medi-Cal that allows caregivers to get mental health services when they bring their babies to the doctor. It's super exciting. The state has also made a groundbreaking decision to put schools automatically in network for all health plans, meaning schools will become just as important as hospitals and ambulances and doctors' offices to the future of our healthcare system. And finally, I mentioned this idea that juvenile justice systems are spending the kind of money that is eligible for a federal match. Get your hustle on. You could distill my career to hunting for those non-federal dollars to match. So these are the sort of essential elements of change that you should be watching in California's system and represent an opportunity for you. Don't get lost in all the unique programs. It's a ton of money, and it's coming from the CYBHI and CalAim and from a bunch of budget decisions. But what I would say is let your gaze soften and lift up, because here are the 4 things you should track. So I'll call these the FOMO on CalAim slide. Okay. First, there are new non-clinical benefits in the managed care plans called enhanced care management and community supports. You need to know what those are because they impact directly the children and families you serve. And by the way, they pay pretty good. Second, there are new mental health benefits available through the managed care plans that you probably know very little about. This is the dyadic and family therapy benefit. You now qualify for mental health services based on an experience of discrimination, or adverse child experience, throw diagnosis out. We are finally acknowledging that racism and poverty are driving the youth mental health crisis, not individual psychopathology. There are new provider classes, doulas, wellness coaches, peers, that are essential for you to track, because a lot of the people who are doing the work in juvenile justice stakeholder settings already do this work, but they aren't certified and aren't seeking reimbursement. And finally, the fee schedule in schools. So I'll use my last couple minutes to take you through just two of them. I mentioned this extraordinary work that colleagues at the state at HCI are doing. When you think of a new provider, you have to think about the scope that they operate under. What codes can they bill under, in what setting, and under whose supervision? You have to understand who gets to say they are who they say they are, credentialing. They have to know how to sign up to get paid. We call that paneling healthcare. We have to know which of those bubbles pays them. And you have to understand the rate structure so you can determine if they will cover cost or if they're a revenue enhancement, meaning a way to get more money on something you're already doing. And why this is so important is if you're a kid in a high school, remember 70% of licensed clinicians are white, 80% of kids on Medicaid are kids of color. If you're a kid in a high school doing peer-to-peer work, you could now graduate and become a peer specialist. You could go on and become a CHW. You could become a doula. You could become a wellness coach with an associate's degree or bachelor's degree. We're also allowing interns and associates now to bill in FQHCs, and finally a licensed therapist, meaning we're reimagining the health career pipeline for young people to become healers, lives with meaning and purpose. Finally, something that just launched right now that Autumn is also leading is this idea that schools are just like emergency departments for a certain set of services, meaning that health plans must pay for all of them. They can't say no. As long as the claim is submitted correctly and the school and its providers sign up appropriately, and this is really important, this service includes psychoeducation, screening, therapy, and case management. And it's really important to note that it's not just schools. Schools are really busy. They are overwhelmed trying to staff their classrooms, find textbooks, and keep the buildings clean. One of the most important under-leveraged opportunities with the fee schedule is to co-locate community-based organizations who already have an electronic health record, who already know how to bill, and have been doing this work for decades. So I think you're going to see increasing focus on that. Who's eligible to participate? It's the school districts themselves, but really important for juvenile justice stakeholders is it also includes community colleges, CSUs, and UCs. The whole nation is watching this experiment, and like all big things, it's going to be tough. It's going to take a long time to get it right. It just launched now. So let me end with a couple key takeaways. Really big things are actually happening. So if Medicaid makes you want to quit or makes you sick to your stomach and you're like, man, that thing sucks, it's actually changing. It's changing at a scale and a scope none of us have ever seen before. So ditch any past misconceptions about it and embrace the opportunities, because every single kid and family you serve qualifies. Medi-Cal is not one thing. It's many things. So understand the many faces of it, particularly the managed care plans and the county mental health plans. That's where the game is played for justice-involved kids and families. Understand the new benefits, specifically those 4 that I took you through: enhanced care management, community supports, dyadic and family therapy, the new provider types, and the schools. And mine those new provider types, because we can shift the economic benefit of safety net systems to the people they were intended to serve if we have the will and the skill. And I just want to acknowledge to anyone who's out there doing this work, there has been tons of one-time money. There's a consultant on every street corner. Breathe out. No one can do it for you. You have to learn it. You have to know it. Take that one-time money, and if it isn't clear to you how you'll sustain it, that's because you're looking at it right. The sustainability picture is murky. Most of this reimbursement comes in what we call CPT codes, and it takes a lot of volume to get to cost. So start slow, manage your expectations, and don't depend on people to teach it to you. Learn it yourself. I'm going to stop. Thanks, you guys.
Thank you so much, Alex, for such incredibly useful and digestible information. We really, really appreciate it. While you all process any questions you might have, we would love to do another temperature check and just get a feel from you of how that information resonates with you, how useful it might be to your work. So in just a moment, you'll see another poll, same two questions, different topic, pop up and give us a sense of the utility of this information to your daily work and how likely you are to use it for your next steps. And while we do that, please do feel free to drop your questions in the chat. We have Alex for a few more moments. I wish we had a few more hours to sit at your feet and hear your take on how we can all benefit from these great opportunities. But we do have a few minutes, so please feel free to drop your questions and keep answering the poll. Thanks for these responses.
Kimberly asked a great question in the chat that I'm not sure everyone can see. Do criminal background issues impact these career opportunities? And I would need to punt that to HCI because I don't know them all. There are some. We train justice-involved youth and young people exiting the foster care system to be EMTs and paramedics. And we can almost always get their criminal background check cleared. There's a handful of offenses that actually do disqualify them. But I think Juan Carlos or maybe someone from HCI, if they're still here, could probably comment on the specific background issues with wellness coaches, CHWs, doulas, and peers.
I think our HCI folks had to jump off, but we are going to keep track of these questions and do some follow-up. So, did you want to add, Dr. Aguayo? You're welcome to.
No, I wanted to say that I wanted to defer to HCI so that we can find that information for the audience. Thank you.
Other questions? You all have had such great questions throughout the webinar. I want to make sure anything that's on your radar now we address while we have you. Okay. All right. Well, if you think of something, feel free to drop it in the chat. Go ahead, Alex.
Yeah, so I want to close with just because it's an occupational hazard of knowing me to hear about EMS Corps, I dropped it in the chat. There are 11 new EMS Corps sites opening in California in the next 10 months. I think a map is on that website. EMS Corps currently operates in 3 sites, has trained 600 justice-involved and foster care graduates over the last 12 years. 4 have become physicians, 128 firefighters, hundreds of paramedics. Young people will save themselves and the rest of us if we give them a chance.
Thank you, Alex. And Alex will still be here, I think, with us to the remainder of the webinar. So if you think of other questions for him, you're welcome to post them to the chat. In the meantime, we will move to our last speaker, Dr. Juan Carlos Aguayo, and he will speak to you all about taking action through some next steps and resources.
Yes. Thank you, Tara. Okay, next slide. Yes, good afternoon, everybody. I would like to start by telling you a little bit about myself and my team, the OYCR Health Policy Division. By training, I am a board-certified child and adolescent psychiatrist. My youth justice work began in 2007 at the CDCR Division of Juvenile Justice, or DJJ. My job at DJJ was to clinically supervise all the psychiatrists and to develop and ensure implementations of mental health policies and procedures. About a year ago, I had the incredible opportunity to join the OYCR team as the Chief Health Policy Officer and return to my passion of serving youth in the juvenile justice system. Next. The Health Policy Division helps our partners with policy implementation strategies to improve the physical and behavioral health services to reduce or eliminate symptomatology and support the overall wellness and healthy living for youth in the juvenile justice system. The Health Policy Division is composed of our subject matter expert for adolescent and problematic sexual behaviors, Dr. Chris Hunter, Dr. Josefa Rodriguez, Health Program Specialist, and Cole Lancaster, our Family Engagement Specialist. I'm happy to report that today, Mr. Manny Rios joins our team as a Health Program Specialist, and next week, Lisa Tadlock also will join our team, completing the staffing for our division. Next slide, please. The Health Policy Division is intimately involved in the California behavioral health reform efforts to ensure that our juvenile justice youth receive maximum benefits from all these amazing initiatives and projects that are or will be improving the behavioral health of Californians. Today, we discuss several important efforts that can benefit our youth, but there are many more that are part of the larger behavioral health reform, such as the CYBHI School Link Behavioral Health Services. There are wellness coaches, the Department of Healthcare Services Behavioral Community Supports, Our Hope, Medical Mobile Crisis, and 988 expansion. Also, the Behavioral Health Bridge Housing, the California Behavioral Health Community-Based Organized Network of Equitable Care and Treatment, or BH Connect. And let's not forget the behavioral health transformation that is also called Mental Health for All from Proposition 1, along with the Behavioral Health Continuum Infrastructure Program, or BISHOP, that will provide infrastructure for the behavioral health transformation. Next slide. You may be asking yourself, what are things that I can do today to take advantage of all these initiatives? Start by exploring the websites for these initiatives, and programs. The websites contains document explaining the goals of each initiative, the dates of upcoming informational webinars, past webinar transcripts and PowerPoints, the application for funding, dates and hours for their office hours, fact sheets, cheat sheets, learning collaborative, dashboards, flyers, and much more. By exploring these websites, I think it's important to understand that this is the pathway to learn more in detail what is going on in juvenile justice in California and the incredible reform effort that is taking place. I know there's so much happening at the same time, and it can be overwhelming. OYCR can help. You can contact us so we can guide you, brainstorm with you, connect you. We're here to support you, support our youth. In the screen is a list of websites, important websites that you can explore. And you can start by the 4 highlighted by Alex, but explore, look at everything that is going on. And we're providing a list of these websites to you so you can start exploring. The ones with a red $ represent those that have funding involved. Next slide. And now I would like to invite all of you to our first OYCR Youth Justice Summit taking place November 5th and 6th at the Hyatt Regency Orange County in Garden Grove. OYCR is bringing together juvenile justice system partners for a day and a half of relationship building, learning from one another, reporting out on the status of juvenile justice in California, and vision together about where we're going. The summit is a great opportunity to build individual knowledge of innovation, learn best practices, have discussions on complex issues, find collaborative and creative solutions, and increase learnings that can be implemented sustainably when you return to your role in your jurisdiction or community. During the summit, you will be able to examine and adopt best practices for youth justice post-DJJ realignment that are targeted towards building systems for successful transition of youth into adulthood. And we will be providing the registration in the chat. Next.
Dr. Aguero, before we go on, there's a great question from Becca about whether the summit is only in person or if there are remote options.
The summit is only in person. Thank you.
Thank you.
And now we will have the final poll, and we want to learn the areas that you would like more training and technical assistance. So I'm going to turn it over to Tara, I'm sorry. Thank you, everybody.
Thank you so much, Dr. Arguello. So last poll, and this one is, you should be able to see on your screen now, open-ended, and we will capture these. We're very interested in knowing what areas you would like additional resources, information, training, and technical assistance. I should say while you do this, you will receive all the resources from today's webinar in a follow-up email later this week. But beyond the information in this webinar, what other things do you want to know? What other things do you want to go deeper on? This will really help the office with its future planning efforts, not just in webinars, but in other trainings, even in the summit. And so we would love to hear from you. That box is open. You're welcome to submit that, and we will save those responses to guide our future work. We've reached the end of the webinar. I'll pause for just a moment so that you all can process and think about other requests you want to make, and then we will give you some next steps and a forward look for what's coming up. Okay. You all are free to continue. We'll leave that open until we close the webinar. You're welcome to continue dropping those requests there. We just would like to close our webinar today by doing a couple of things. First and foremost, a huge thank you so much to all of our speakers for their impactful and insightful presentations. We thank you for your time and your energy today. Thank you to all of our participants for joining and for your attention and engagement. We welcome you next to take a survey about today's webinar to provide your feedback about your experience. You'll find that link in the chat momentarily. We really value your feedback and we use it for our future planning efforts. After that, if you would please save this link, you'll hear about this a couple times if you're on the OYCR webinar list. We're also conducting a survey on the series as a whole. If you have ideas for topics that you'd like to hear about or learn about, or even the scheduling, the time and date of this webinar, we welcome you to submit your responses to that survey. So again, there will be two survey links in the chat, one about today's webinar, which we invite you to take and give us feedback on your experience, and one about the series as a whole that we invite you to save and take later when you have a moment. We would love your feedback on the series as a whole. Before we completely close out, if anyone from OYCR would like to say any final thoughts, you're welcome to chime in and share. Otherwise, I will just give you all a heads up that the next webinar in our Youth Justice Action series will be October 7th at noon. We welcome you to join all of us. Welcome all of you to join us there. We thank you once again for your time and attention. We will leave the webinar open for another moment or two, just to be sure that anyone who has requests for training and technical assistance can do so. And please do fill out the survey for today's webinar. Thank you so much, everyone, for joining us, and we will see you next month.